He's a pediatric neurologist and a neuromuscular specialist with clinical interest and research interest in inherited neuropathy specifically. He works at Children's Hospital, Westmead, Australia. So his dedication to inherited neuropathies clinically and with respect to research has actually enriched our understanding of these conditions and has also brought hope to all the individuals, countless number of individuals and families who are suffering from such conditions. So today, please join me in welcoming Dr. Manoj Menzies for his talk on inherited neuropathies and standards of care. Over to you, Dr. Manoj.
Hello, everybody. Thank you very much. That introduction was very kind. Can I just first check that you can all hear me clearly?
I think we can hear you.
Okay, that's great. If you cannot, or if you wanted me to speak up, just let me know. Okay, I'll see if I sharing my works out with me sharing my screen. All right, can I just check that you can see that PowerPoint there titled Treatable Inherited Neuropathies?
Yes, we can see that.
Okay, excellent. Thanks very much. I don't know about how we'll go with questions, but maybe people can put them in the chat box if you do have any questions, and I can get to them once I finish with the talk. Is that okay?
Yes, that should be fine. We'll go ahead and.
Okay, excellent. Thanks very much. Look, thank you, Anne, for asking me to speak, and ORDI for facilitating this process of us learning more about inherited of neuromuscular disorders. So this talk is titled Treatable Inherited Neuropathies. I gave this talk at the AOCN meeting in February. So apologies to anyone who was there and has already heard the talk. These are my disclosures. So for the purpose of today's talk, what I've done is classified childhood neuropathies into those that are acquired and inherited. Of course, all know about the acquired inherited neuropathies, Guillain-Barré and CIDP. I won't be talking about those today. And the inherited neuropathies, I like to classify them as those that are primarily or predominantly associated with peripheral neuropathy, and we call these CMT or Charcot-Marie-Tooth disease, or those that are syndromic, where the peripheral neuropathy is also associated with the involvement of other systems, be it dysmorphism, seizures, global developmental delay, or a myopathy. And these can again be classified down into complex genetic syndromes and metabolic neuropathies. In today's talk, I'll just be talking about CMT and metabolic neuropathies. So the outline of my talk today, it's titled Treatable Inherited Neuropathies, and I'd like to convince you that all inherited neuropathies are treatable. And I'd like to discuss our recently published pediatric CMT management guidelines and some work we have done describing the relationship of weight and body mass index with CMT progression. Many of these inherited neuropathies may one day be curable, and I'd like to raise the examples of some of the treatable inherited neuropathies recently described, as well as early work in animal models showing the effectiveness of gene replacement therapies. I'll then talk about some treatable metabolic neuropathies not to miss. And finally, I'll end with talking about riboflavin transporter deficiency as a classical model for treatable neuropathy. So we've recently published some uh, practice guidelines for the management of childhood CMT, because previously these guidelines were lacking and there was a great variability in how different centers or different individuals treated children with CMT. And these guidelines were formulated using a CMT best practice guidelines consortium that consists of adult and pediatric neurologists, rehab physicians, and allied health physicians, including physiotherapists and occupational therapists. And the guidelines were organized using a modified Delphi methodology. The amount of evidence that we have with the randomized control trials for interventions in CMT are limited, and hence we had only 3 evidence-based guidelines, but we were able to develop 31 consensus-based recommendations for the management of childhood CMT. I won't talk about the guidelines in detail. You can access the paper. If anyone has trouble accessing it, please drop me an email and I'm very happy to send you a copy. So the first guideline, evidence-based guideline, was developed based on a randomized control trial we had done at the Children's Hospital at Westmead. And this trial, led by Professor Josh Burns, showed that moderate intensity progressive resistance exercise of the ankle dorsiflexus, so the most affected muscle in most forms of CMT. So exercise for 6 months, as you can see in this graph here, slowed down the progression of CMT, resulting in a significant difference in the ankle dorsiflexion strength at 24 months. So the first evidence-based guideline says that we recommend the use of progressive resistance exercise training of the ankle dorsiflexus to improve muscle strength and slow the progression of muscle weakness. So ascorbic acid and botulinum toxin are not effective in preserving muscle strength, but progressive resistance exercise is, and it slows down the progression of ankle dorsiflexion weakness. In addition to ankle dorsiflexion weakness, the other major problem that we see in children with CMT is severe and progressive ankle contractures. This is a consensus-based guideline. What should we do for these ankle contractures? It is useful to do stretching, but the only intervention that's effective in managing ankle contractures is serial casting of the ankles. So we put kids in a mid-calf cast, and we slowly tighten it once a week or twice a week over a period of 4 weeks, resulting in an increase in the ankle range. If you cannot do serial casting, then serial night casting may be a useful alternative. Evidence consensus-based guideline number 3, what should you recommend for children with impaired mobility? So AFOs are quite useful in carefully selected children with impaired functional ambulation, and we use them for foot drop. So when there's significant ankle dorsiflexion weakness, children with CMT are having frequent trips and falls, usually due to ankle dorsiflexion weakness and for ankle instability. Inciorthosis may be used for children who have foot deformity and foot pain. All right, the next came a consensus-based guideline was when to refer to an orthopedic surgeon. So when your previous interventions have not worked, so when you have painful, disabling, or progressive pes cavus that does not respond to conservative measures such as ankle foot orthosis, then refer to an orthopedic surgeon who is skilled in the management of childhood CMT. Similarly, ankle contractures that have not responded to stretching and serial casting, you may see an orthopedic surgeon. When there are features of hip dysplasia or you have moderate scoliosis. Now, even milder forms of CMT, such as CMT1A, 10% of children develop hip dysplasia. It is not always developmental or congenital or early onset. First thing. Secondly, it's not always related to the severity of weakness. So we recommend that a hip X-ray should be considered in all children. And at our clinic, we do standing APs of the pelvis every 2 years in all children with CMT till they reach the age of transition to adult services. Finally, care for respiratory strength is also important, usually in forms of CMT that are more severe than CMT1A, for example, CMT2A due to mitofusin mutation. And we refer them to a respiratory physician when they have features of sleep disordered breathing, such as slurring or daytime somnolence, when their FVC is less than 60% predicted for age, when they have a significant scoliosis, frequent respiratory tract infections, and all non-ambulant children. All right, so those were the guides, some selections from the guidelines, and there are other consensus-based guidelines in that paper for you guys to have a look. All right, this is some work that we had done trying to correlate weight and body mass index with CMT. And we looked at 477 children with CMT. And you can see on the left side of this slide here, we have compared their BMI on the IOTF scale with the CMT pediatric scale on the vertical axis. Now, the CMT pediatric scale is a functional disability outcome measure, and it uses 11 different items of upper and lower limb strength, upper limb function, gait, and balance to give a score out of 44. And this is compared to age and sex matched norms. And 0 means that you are completely unaffected, and 44 indicates you're severely affected. And when we saw our cohort of children with CMT, you can see that those that are severely underweight, those that are underweight, and those that are obese have much greater disability than children of a healthy weight. This was cross-sectional data. We then went on to look at a progression of CMT, and similar to the baseline data, you can see those that are severely underweight and those that are obese have a much more rapid rate of progression of CMT compared to those of healthy weight. So if you have a BMI that's in the extremes, you're more disabled at baseline and you progress more rapidly. Now, this is data. This is a cohort study, and but we haven't done an intervention trial yet, which is our next process. But there is some evidence here that keeping your BMI in the healthy range may improve the disability from CMT. All right, I'll then go on to whether inherited neuropathies are curable, and I'll use some recently described treatable inherited neuropathies. Now, the first one I'd like to talk about is SORD. I'm a child neurologist. SORD is usually not diagnosed in childhood, and most are diagnosed either in early or late adulthood. However, the pathway behind and the treatment process for this is quite interesting. Now, SORD neuropathy is caused due to recessive mutations in sorbitol dehydrogenase. And because of this, there is an intracellular accumulation of sorbitol, which is toxic to the cells. And individuals also have a raised fasting serum sorbitol. Now, aldolase reductase inhibitors normalize these intracellular sorbitol levels and also improve the phenotypes both in the fruit fly and in patient fibroblasts. And Applied Therapeutics is now running a clinical trial in the US of an aldolase reductase inhibitor that some of these are already approved for use in diabetes. And I just saw yesterday that they have now applied to the FDA for accelerated approval of the aldolase reductase inhibitor that they are trialing based on their early data. So that sounds a very promising treatment for an inherited neuropathy. Another adult onset inherited neuropathy is HSAN1. It's a sensory neuropathy. It's caused due to mutation in the SPLECT1 and SPLECT2 genes. Now, these are serine palmitoyl cotransferase genes, so they add L-serine to the sphingolipids that are important uh, for nerve structure. And when there's dysfunction, instead of L-serine, you add glycine or alanine, and this results in the formation of these toxic deoxysphingolipids and hence a axonal, mainly sensory neuropathy. And so loading or giving L-serine not reduces the levels of the toxic deoxysphingolipids both in mice and in humans. And Vera Friedman did a randomized control trial of high-dose L-serine supplementation, where she showed improvement both in the CMT-NS as well as reduction in the deoxysphingonine levels. So another treatment for an inherited neuropathy. Finally, you may all have heard about PXT3003. Here, the story is not so promising as the earlier two medications. It was a medication identified by a systems biology approach. It had low dose sorbitol, baclofen, and naltrexone. Now, you might find the presence of sorbitol interesting here because subsequently we have identified it as being toxic in SORD neuropathy. Early studies showed that this combination decreased PMP22 mRNA in CMT1A rats. And the early phase 2 study showed some improvement in the ONLS scale. They then did a phase 3 study, which showed benefit with the high dose, but there were problems with the stability of the high dose. So individuals who are on it could identify that they were on the medication, and the EMA asked them to do another phase 3 study. And that's, I think, the early results were out in December. And unfortunately, they showed an improvement in both the treatment and the placebo arm. So that trial didn't reach significance. So it doesn't look like the company will be taking PXT3003 ahead for further use in CMT. All right, now we have all heard the fantastic story of genetic therapies for neuromuscular disorders. We have the use of both gene replacement therapies as well as other genetic therapies like ASOs for SMA. And some of you may be involved in clinical trials of gene replacement therapies in Duchenne muscular dystrophy. For CMT, we are at an early stage yet. Uh, Jerry Mendel's group in Ohio is doing a trial of IgHMBP2 gene replacement therapy in SMARD. And I think they have recruited 6 out of 10 individuals. So we'd be quite interested in seeing the progression, the results from that trial. And then Cleopas group uh, have shown the benefits improving both neurophysiological and behavioral phenotypes in mice with GJB1, SH3C, TC2, and FIG4. So I'm quite hopeful that some of these gene replacement therapies should be available to our patients initially as clinical trials and if successful as therapies quite soon. All right, so now I'll move on to treatable metabolic neuropathies. Metabolic neuropathies are rare but important to recognize, especially if they are treatable. There is a long list of metabolic neuropathies. Some of them are listed here. I won't describe these in detail, except to talk about vitamin and nutritional metabolic neuropathies. Now, I've included these in a talk about treatable genetic neuropathies because rarely some of these are also caused by genetic mutations. You all know about the B12 deficiency causing both spinal cord and peripheral nerve problem. Interestingly, pyridoxine or B6 causes a neuropathy both as a deficiency, but you would have more commonly seen it causing a toxic neuropathy when used for pyridoxine dependent epilepsy. Vitamin E deficiency, both genetic or nutritional, causes a neuropathy, copper deficiency, and I'll come to riboflavin. So when you see a child with a slowly progressive neuropathy, please think about the nutritional neuropathies, and the tests are easy to do. Supplementation is also quite easy. All right. Sometimes metabolic neuropathies may masquerade as inflammatory or acquired neuropathies. The classical mimic of Guillain-Barré syndrome is acute intermittent porphyria. Uh, it causes a GBS-like rapidly progressive, sometimes ascending quadriparesis. What to look for is often these kids will start off with abdominal pain prior to the onset of their neuropathy, and during the illness also develop psychiatric disturbances, uh, seizures, confusion, and dysautonomia. Sometimes the seizures and confusion are put down to an encephalopathy due to the dysautonomia, but maybe due to AIP. Again, it is not a demyelinating, but an axonal motor neuropathy. That may be one of the clues. Of course, you look for elevated serum or urinary porphyrins. Important to recognize as the hospital stay and recovery is much quicker with intravenous dextrose and intravenous hematin. All right, so here is a list from the Treatable ID website. I find this website very useful, so I thought I'd share it with you. You can put in whatever symptom you want, and it'll give you the list of metabolic conditions that are associated uh, with that symptom. If you put in neuropathy, this is the list it provides. Of course, we discussed some of these just now. Vitamin B12 with transcobalamin deficiency down there, mitochondrial neuropathies down here. And of course, these are again important to identify because there are treatments available for most of these conditions. Of course, the one that they are missed in there is a disorder that I'm very interested in, which is riboflavin transporter deficiency. So I'll now move on to talking about riboflavin transporter deficiency as a model of a treatable neuropathy. So riboflavin transporter deficiency used to be called Brown-Violetta-von Lehr syndrome, uh, eponymous syndrome for the individuals who described this a century and a half ago. And the initial description here from Charles Henry Brown was of a type of infantile progressive bulbar paralysis, and he compared it to a progressive poliomyelitis of adults, which was like an ALS. And you can see this boy that he described with this severe wasting of his upper limbs, but still able to stand. Subsequently, we and others describe mutations in the riboflavin transporter genes as a cause for Brown-Violetta-von Lehr syndrome. The disease is now renamed as riboflavin transporter deficiency. So there are three important riboflavin transporters. RFVT1 and RFVT3 are important for intestinal transport. Only mutations in RFVT3 have been identified in riboflavin transporter deficiency. And of course, RFVT2 is the neuronal transporter, again known to cause RTD. So this is a video of a couple of my patients. They are twins. They were already significantly affected before they were diagnosed and treated. So this is what untreated RTD looks like. I hope you can see the video there. Please let me know if you cannot. I might play that again, but what you saw there was both of them are in wheelchairs because of severe ataxia. They do have reasonable lower limb movements that you saw there, but very severe upper limb weakness, almost causing a child in the barrel syndrome, where they look as if they're constrained within a barrel. You can see the boy on the left of your screen there. He has continuous ventilation. His brother is on BiPAP. Both have nasogastric tubes due to severe bulbar dysfunction. If you look at their hands, you can see the severe wasting of the intrinsic muscles of their hands. So because of their bulbar dysfunction and severe auditory neuropathy, they communicate with each other by using their legs. Okay, so that's the phenotype of RTD. It is a childhood onset disorder. Often the onset is with severe sensory neural hearing loss, sensory ataxia, or with an optic neuropathy or bulbar weakness. But untreated children usually progress on to develop motor weakness. And this is generalized in RTD3, which is due to mutations in RFVT3, or upper limb predominant, as you saw in that set of twins in RTD2. And so we think this boy described by Charles Henry Brown in 1894 actually had RTD2 rather than RTD3. And of course, death may follow due to respiratory failure and diaphragmatic paralysis. So that was untreated RTD here on the left of your screen. But this is our cohort of children who were diagnosed early in their disease course and treated. Now the top two are again siblings with the same mutation as these twin boys that you saw earlier. And at the same age here, they are also 16 years of age, the same age as the boys in the videos. But you can see that their outcome is much better. Maybe mild ataxia is all she has. Her sister has more severe ataxia and a scoliosis, and she also has a cochlear implant, but you can see she's still very much ambulant. Of course, some children have improvements, but are still left with significant disability. This boy has a more severe mutation in RTD2, and he was in ICU, ventilated, and he has improved there, but you can see that he is still left with a significant ataxia, upper limb weakness, and you can see he has a cochlear implant because of his auditory neuropathy. So what is the benefit with riboflavin? We treat all our children with RTD with high dose riboflavin, grade up to 50 milligrams per kilogram in those less than 40 kilos, and 2 grams per day in those more than 40 kilograms. And you can see here the progression of our cohort of children. So while they do show improvement over time, some of them do worsen a little bit and they are left with disability. This is using the same score, the CMT pediatric scale that you saw in that earlier BMI study that I showed you. So what happens? We use the GMFCS scale, and you can see that there is a significant improvement in their motor functions, but a small number of children are still left with disability. And hearing loss, again, you can see the improvement is not as dramatic unless identified early in the disease course. So there is improvement, but a number of children are still left with profound or severe hearing loss. So you can see that riboflavin, diagnosing riboflavin transporter deficiency is important. You need to do it early before you lose your sensory ganglia and anterior horn cells. But still, individuals may be left with a significant disability. Monitoring them is important. So Jack, who you saw did the earlier study, has also developed an outcome measure, and we are now routinely following these children up, and we're happy to share this outcome measure if other individuals, any of you has children with RTD that you'd like to follow up in a very standardized fashion. Of course, maybe riboflavin is not enough. We are yet to understand the exact pathophysiology behind why riboflavin transporter deficiency causes a neuropathy. So, among the various efforts, we have also developed a worm model of the disease. So I'll end with the slightly lighter note here, describing our worms who, like humans, also have RTD, and we used CRISPR-Cas9 to knock in mutations into these worms. And what we saw was they had lower body width, which indicates a lower cell number. We saw that the defecation cycle was shortened, again indicating poor nerve function. Those worms with RTD, just like humans, moved or thrashed less. On the top, you can see a normal worm which does not have riboflavin transporter deficiency, and this worm here, we've unfortunately given that one RTD, so you can see it thrashes less than its normal counterpart. And when we looked at synaptic transmission, that was also abnormal, indicating an axonal neuropathy. And we are hopeful this work in developing a worm model and the outcome measure, together with work being done on iPSCs with RTD in Enrico Bertini's lab, and development of a mouse model in the Jackson laboratories, will all help us understand the pathophysiology and also maybe develop other treatments that will be used together with riboflavin. So I'll end there, and hopefully I've convinced you that our recently published CMT practice guidelines are a useful resource for the routine day-to-day management of children and young adults with CMT. Advances in our understanding of the metabolic and genetic advances that cause CMT are very likely to result in disease-specific therapies, and early diagnosis and early management of riboflavin transporter deficiency is essential to achieve the best outcome. All right, I'll end there. I'll invite all of you to our annual Australia and New Zealand Child Neurology Society meeting. It's being held on the beautiful slopes of Queenstown. So if you want to hear some pediatric neuroscience or you just like to ski, you're all welcome to Queenstown in New Zealand. And I'll end, of course, by thanking other members of the group who have done most of the work that I've described today. Thanks very much. Happy to take any questions.
Thank you, Dr. Manoj. That was a wonderful presentation, and it's something for me as well, where inherited neuropathies do not just end at diagnosing or getting a genetic testing done, but there's a lot more after that. How to focus on the treatable aspects, how to focus on the cure, going forward, and especially looking for uh, diseases like SOD for the aldolase reductase inhibitor and other neuropathies, as you said, riboflavin transporter deficiency. Good learn. So the session is open for questions. Um,
I have a question. This is Dr. Manoj, thank you so much. I was able to get a bit more from this talk this time. So I'm very glad I'm listening to it again. Um, this becomes very important because of I'm more interested, I'm a pure clinician. I'm more interested in the outcomes, the outcome measures and things like that. Because it's a good point that Dr. Veena had raised with regards to the fact that, yeah, it doesn't stop with getting diagnosis, because thanks to the explosion of genetics, we are getting a lot of diagnosis, but we are not proceeding. So we are actually having some of the people, some of our audiences are um, pioneers in rehab. So there's Dr. Vinita in the team as well. I'm glad she's there with regards to serial casting. So I don't know how many of us do serial casting. In our unit, we do serial casting. Does anybody else do serial casting? So that's one question. So that's for the audience at large. But from a serial casting perspective, we are a bit new in doing serial casting for neuropathy. After listening to you in February, we've been aggressively serial casting our neuropathies. Uh, the question was with regards to how much to strengthen them, the strengthening exercises for the dorsiflexors. How do is there any resource for that where we could go do that?
Yeah, I'm also interested in hearing about the experience of the larger group in using serial casting. So I'll first talk about the serial casting. We use it routinely for children who cannot get their ankles to plantigrade, so to 90 degrees. We believe it works well if you do it early. We don't do it any more frequently than once a year. We try to get them to neutral. If we manage that, then we try to maintain it with bed resting AFOs or night splints. And we have found that quite useful, and it often delays or prevents the need for surgery. So that's serial casting. Sorry, what was your second question, Anne?
It was about the strengthening. How
Oh,
much to
yes.
strengthen?
Strengthening, you'll see if you come to our guidelines, there are two recommendations there. The first is for ankle dorsiflexion strength. We used a very standardized protocol where we used progressive resistance exercise. So there was a cuff. We measured the maximum ankle dorsiflexion strength. Then we provided 50 to 70% of that. So it's all there in the paper, but you don't need to do it that way. Any ankle dorsiflexion strengthening is good. There is also another recommendation that keeping the proximal muscle strong, whether that's by strengthening exercise or by regular exercise such as swimming or aerobic exercise is just as useful. Now, the other important thing that we found in our ankle dorsiflexion strengthening trial was that we didn't see any overwork weakness. So a big concern has been previously that you might result in damaging the muscles if they are denervated, but we didn't find any of that either clinically, and we used a safety outcome of intramuscular muscle and fat volume using an MRI, and there was no deterioration. So we suggest kids do enough exercise so that if they're a bit sore that day, it's fine. But if they're too sore the next day and can't go to school, that's too much. So that's the grading that we use. I'm happy to share the resource with whoever is interested on a very standardized protocol, but you don't need to use that. The use of a physiotherapist may be 50 to 70% of their maximum ankle dorsiflexion strength, and resistance weight training is probably good enough. There is a instruction there about hinged versus rigid AFO usage in neuropathy. That's a very excellent question. A lot of our patients and many of the physios that talk to us, this is an important question. The benefit of a hinged AFO is the mobility or the flexibility it provides. Nowadays, there are newer AFOs which are called leaf springs, so very thin one at the back, so you uh, uh, don't need a hinge. It's a hinge like others have a hinge. We use hinged AFOs. If you have adequate ankle dorsiflexion strength to make use of the hinge and don't have significant proximal weakness. Once your ankle dorsiflexion strength is less than 3, it's unlikely you'll be able to make much use of the hinge. Or if you have a proximal weakness, you might go into a crouch position. We then give the children a fixed AFO. Sometimes the differentiation is not easy. We ask them to trial one and the other and see what's best. Sometimes fixed AFOs are good for routine use so that you don't trip and fall, but kids use hinged AFOs maybe sometimes easier when you're doing stairs or playing on the playground. So it's a balance between flexibility and function. Yes, happy to. Why don't somebody has asked for the articles? Maybe I'll share the one on the FAST trial and the one on our CMT practice guidelines with Anne, and Anne can circulate it to the rest of the group. I hope that's okay.
There's another question from Dr. Vinita Verghese. She says, if you have had a need to recast when you serially follow up children, and also do we get a similar fat muscle volume if we use ultrasound instead of MRI?
Oh, that's an excellent question. Recasting, yes. As I said, we sometimes recast our children as frequently as once a year. We don't do it any more frequently than that. If the children are pretty good with maintaining their stretches and using their bed resting AFOs, we give everyone, we almost refuse to do serial casting if the children don't agree to use their bed resting AFOs. So these are AFOs that you use at night to maintain ankle dorsiflexion range. And with the use of that, we have found that usually we don't need to recast them more than once every 12 months. But yes, there are a number of children where we recast them uh, once every 12 months. You know, it takes 3 or 4 weeks and then they're good for the next 12 months. So we think that's useful. With serial casting, you can walk in those casts. You can't get them wet, so you can't swim, and you have to cover them when you have a shower. But yes, you can walk with them. So we usually do it in the school holidays for the kids. A fat muscle volume on ultrasound. I don't know how good we used volume, so that's 3D. There is further data now coming out from the UCL group at Queen Square about the use of staging of muscle cross-sectional area or intramuscular fat as a biomarker for clinical trials. But that these are specific clinical trial measures. I don't think they're useful for routine care. There is some work being done on muscle on nerve ultrasound as a biomarker for CMT. But I don't think you can get good volumes out of ultrasound. That's why we used MRI. I'm not up to date on the data for that. But yes, you could use ultrasound to maybe look at the echogenicity of the muscle and the amount of fat in there. I think that's an interesting question. I don't think we have enough evidence about that yet. Could I please repeat the riboflavin dosage? Yes, I think the great thing about riboflavin is that it is water soluble, so you can't get toxic with it. Really, you can give as much as an individual with tolerate. The dosage is something that I like to discuss in sympathy with my patients. I myself took riboflavin for a week. It is a terrible drug to ingest, and it causes quite severe gastritis. So some of our patients will take it with yogurt or other things like that. It doesn't have a great taste, especially on the volumes that they take. We use 50 milligrams per kilogram up to a maximum of 2 grams. Now you see the dosage is different if you have RTD2 and RTD3. I think most individuals with RTD2, so the intestinal transporter, using a dose of 10 to 30 milligrams per kilogram is probably sufficient. But for RTD3, I think you use, RTD2, so the neuronal transporter, you require much higher doses to force that riboflavin into the neurons. Now, the other thing is riboflavin is by the kidneys. So you need to give it in a divided dose. Our patients are advised to take it 3 times a day in divided doses, 3 or 4 times a day. And recently there's been a paper that says that even taking it in much smaller doses, up to 6 times a day, might be most beneficial. Now, most of my patients are now adolescents. It's a challenge. So it's a balance between getting them to take the medication and giving multiple doses a day. Most of our patients will agree to take it 3 times a day before they leave for school, when they get back from school, and at bedtime. 50 milligrams per kilogram, maximum of 2 grams.
I have a question, Dr. Manoj. So
Yes, go ahead.
about the dosage and efficacy of riboflavin in these three forms of RTD, RTD1, 2, 3. Has there been any difference that you have noticed, or the amount of improvement that was seen was different in among the three varieties of RTD?
So RTD1, we don't have any, there's been no patients described anywhere with mutations in RTD1. So we don't have any individuals with RTD1 or RTD2 and RTD3. They are slightly different diseases. You see in RTD2, you get more generalized weakness, often more cranial neuropathies, uh, like facial nerve weakness and bulbar weakness is more severe. RTD3 present with sensory ataxia, that's more common, hearing loss and upper limb predominant weakness. Uh, Hard to compare the two. Most of our patients are RTD2 because we have a Lebanese founder mutation. I think the outcomes for RTD2 are not as good as those with RTD3. It's probably some of the problem is getting riboflavin to cross the blood-brain barrier and get into the nerve cells. That seems to be the problem. RTD3, it looks like you can force the riboflavin across the gut into the bloodstream. But again, our effort with developing the outcome measure is that so we have a standardized way of measuring this. So that was a long answer to your question. The short answer is probably we don't know because we haven't been collecting data in a standardized fashion. And we are hopeful in time that we'll have a registry where everyone has a standardized outcome measure. Anne earlier talked about her interest in outcome measures. We now have a website, outcomemeasures.org, where we have all the outcome measures listed, and we have CMT outcome measures across the lifespan. Our group has developed the CMT infant scale, so 0 to 4 years of age, the CMT pediatric scale, 3 to 21 years of age, and now the CMT form for adults with CMT. So you can register and access. There are calculators that gives you the Z score and the total score. And our patients come to our clinic once every year if they have a more severe form of CMT, once every 2 years if they have CMT1A, and then they get this the CMT pediatric scale or the RTD pediatric scale, and we follow their progression.
Thank you. Any more questions if we have?
I had a question. There's a question on WS, and I'll come to that in a second. But I just had a question. If any of the group here has patients with RTD and any thoughts that they had on how the patients have gone with riboflavin. So does any of you have patients with riboflavin transporter deficiency?
I do, but it has only been in the UK,
Yeah.
not after
Yeah.
coming back to India. Yeah. So I was interested in what they were like long term, because some of them didn't fare so well,
That's
especially
what.
with regards to the cochlear and the auditory.
Yeah, so our patients, we have seen that if you treat with riboflavin very early, so probably within 12 months of onset of the auditory neuropathy, then there is improvement. But after that, there isn't. So then you go on to do a cochlear implant after that. But yes, early treatment probably rescues the auditory neuropathy phenotype, but after that, you've lost your vestibulocochlear neurons, just like you lost your sensory ganglia, and that function will not return. Okay, there's a question here from Dr. Pavan about whole exome sequencing and whole genome sequencing in inherited neuropathies. Number one is we try to phenotype our patients with CMT as tightly as possible. So make sure it is CMT and not a more complex genetic neuropathy. If we think it's a CMT, we would always do nerve conduction studies unless someone else in the family has had their has been genetically classified. So if a parent has CMT1A, of course, we don't do nerve conduction studies in the child, but everyone else we do, and only then do we ask for genetic testing. If we are pretty confident this is a predominantly peripheral neuropathy, so CMT, we go for a whole exome backbone panel. So we do a panel. Most of the genes causing CMT are well understood and the phenotypes are well described. And so we use a TrueSight panel, for example, on a whole exome backbone. But if it's a more complex phenotype with central and peripheral involvement, cognitive dysfunction, sometimes HSP plus neuropathy, then we will go for whole exome sequencing. We don't use whole genome sequencing as a first line unless they have been diagnosed, remain undiagnosed on a well done. They're well phenotyped and undiagnosed on a well done whole exome, trio whole exome. Then we go on to whole genome sequencing. I hope that answers your question, Dr. Pawan. Is it okay to start therapeutic doses? Yes, I think that's been one of our strong suggestions. Now, genetic testing is usually quickly available, and you can ask specifically for those genes, but we would always advise, especially in sick kids, for example, those in hospital, rapidly deteriorating ICU, or anyone you suspect of having a riboflavin transporter deficiency, Two things you should do: have a low threshold for doing an acyl carnitine profile. Riboflavin is important for the beta oxidation of fatty acids. So that's in the liver. That's not the cause for the neuronal dysfunction, useful marker, but it's abnormal in only 50%. So it'll give you a clue, but if it's negative, it doesn't exclude the disorder. And so we would then suggest starting riboflavin and waiting the 3 or 6 weeks, sometimes 6 months before you get a genetic testing results. It's a pretty safe medication. It's extremely cheap. It costs us a few cents a day to provide riboflavin. So yes, we would start a therapeutic dose till we get the result. Yeah, and that's an excellent point of discussion. I don't know the answer to this. We often grapple with the same challenge. What you have said is now genetic testing is very accessible, probably easier to access than a child neurologist or adult neurologist or a neuromuscular specialist or nerve conduction study. So patients will come to your clinic with a genetic testing report. In fact, you can see the person who started the RTD cure, he couldn't get a diagnosis for this child. So he himself organized whole exome sequencing and found the diagnosis. So I think it's an incredibly useful tool, and it empowers our patients, but it provides us with some challenges. We have people who have chromosomal microarrays done for something else, and it gives us a diagnosis of CMT1A, but they don't have symptoms, and then it's a challenge on what you do with these individuals in the long term. Again, they come with the report. I think still the phenotype is the most important. Uh, the genes that cause CMT are ubiquitously expressed. So they're not only in your nerves, they're in all other things, all other tissues of the body. So number one. Number two is that a number of changes in these genes may not be disease causing. So I think the first thing we always do, examine the patient in detail, a good motor and sensory exam. The CMT pediatric scale or another outcome measure is quite useful because you can grade the functional disability. We would always do nerve conduction studies then to make sure the phenotype fits the gene. So if you have CMT2A, mitofusin, you have to have an axonal neuropathy. It doesn't cause a demyelinating neuropathy because if it's not expressed in the Schwann cells or myelin, CMT1A or PMP22 mutations causes a demyelinating neuropathy, cannot cause an axonal neuropathy. Look for the other clues, GDAP1, vocal cord involvement, scoliosis in CMT4C. Put all those together. But yes, it can be a challenge when as you say, the cart is before the horse and you have a genetic testing result first. But I think always phenotyping and nerve conduction studies can be quite helpful.
Can I ask one question?
Sure, please.
So yes, as an adult neurologist, we see lots of patients. Yes, they do come with comatose, high arched feet, and then but they do have other possible causes for neuropathies. They come up with diabetes, other metabolic causes as well. So how frequently do you see such scenarios where there is a progressive genetic inherited neuropathy going on along with a metabolic possibilityology, which is causing the worsening.
Yeah, very infrequently compared to you guys. Uh, I did my Churchill Fellowship with Queen Square, and they had this major problem. So many of they would always look for metabolic neuropathy, usually diabetic neuropathy, and number two, paraneoplastic neuropathy in their individuals who had a slowly progressive neuropathy or amyloidosis and things like that. I don't have to worry about those. So my experience with that is limited, so I can't comment anymore. There are, for example, if you go to the neuropathies common website, they have a list of metabolic conditions to test for if you have a inherited neuropathy. So that's number one. I think sometimes a bigger challenge, and I've talked to Anne about this, is deciding whether someone has an inflammatory or an acquired neuropathy when they present subacutely. And that is a challenge. Fortunately for children, we have seen that most inflammatory neuropathy is quite exquisitely sensitive to immunomodulation. So whether that's steroids or IVIG, we would always uh, I think it's very reasonable in some of these children where they have a subacute onset to treat with immunomodulation. For us, IVIG is easily accessible. Steroids are very useful. But if they do not respond as expected, let's say within a 3-month trial, then we would always do genetic testing. We and others have described many forms of demyelinating neuropathy. So FIG4, CMT4C, CMTX1, CMT1A, initially diagnosed as an inflammatory neuropathy. So I think you need to keep your mind open both ways. If your inflammatory neuropathy is not responding to treatment, make sure you excluded genetic neuropathies. People have described inflammatory neuropathies in people with underlying genetic neuropathies. Maybe something makes their nerves more vulnerable, but that's a much rarer condition. But if you have an inflammatory neuropathy not going how you would expect, then please consider genetic testing. But I can't talk any more about. Fortunately, I don't have to talk any more about diabetic. It's a much bigger challenge for adult neurologists.
Wonderful. Uh, Thank you very much. That was wonderful session. It's always neurology. You always learn something new, and neuromuscular is a part of it. Part of it more than what we actually understand. There's something new coming up every single day, and I'm very fortunate to be attending your talk. As I told you, I've read lots of your papers, and then I'm seeing you in person, of course online, but then it feels really great. Uh, uh, Dr. Agnes.
Hello. I'll end with a vote of thanks, saying thank you so much to Dr. Manoj for making this. And Dr. Manoj is not the same as the YOCN, but even if it is a recap, and it had lots of important things. And so when you are saying serial casting, I'm very sure we are rare. We are probably the only unit that is doing it. If anybody else is doing it, we are hoping to spread serial casting. So Dr. Mahima, Dr. Ms. Mahima is our thought she attended the talk, and Dr. What's her name? Dr. Vinita is the one who asked you the question about the orthosis. Dr. Pavan is from our team. So we are hoping to do these simple things. So thank you so much to Dr. Veena. I'm hoping she's the next generation. She's the future. So which is why when I met her, I was so happy to put both of you together on the same stage. And I'm hoping that she's working in a big institution and she has access to many patients. So I'm hoping she can change the future. And you're already changing it. And we're hoping to get. So thank you so much to both of you. And thank you to ORDI once again for making this possible. Thank you. And there are multiple requests that I've been getting on my WhatsApp asking for the guideline. If you can send them to me, if at all possible, Dr. Manoj.
I'll definitely send you a copy of the paper, and happy for you to distribute it among the other members
So
of the group.
3 years ago, you mentioned about the CMT-NS and CMT-ES. Since then, we have been religiously putting all our patients through it.
No, that's excellent. I think we have a lot of opportunity to learn from each other, and you guys have such a wonderful cohort of patients that's so well phenotyped. So I think it gives us lots of opportunity to work together. I enjoyed presenting today, and thank you for inviting me. I enjoyed that.
We even have somebody
Thank
from Sri Lanka. Sometimes we do have people from other countries, sometimes from Iraq as well. Sure. Thank you. Thank you so much.
All right.
It's very,
Good night,
it's very
everybody.
late in your country.